fue muy bonito porque es una experiencia que cada mujer vive. Es un momento muy especial el ver el milagro que Dios hace. Esta vez fue diferente porque con Él compartí desde ese momento. Me trajeron a la sala de recuperación y ya estoy con Él.
Este es un taller centrado en el cuidado esencial del recién nacido, en el minuto de oro y también en el cuidado del niño pequeño. Nos hizo traer una gran responsabilidad para poderlo replicar en nuestra institución y no esperamos mucho tiempo para hacerlo y lo replicamos en 5 diferentes grupos, tanto de enfermeras como médicos, que están involucrados en la atención del recién nacido en este centro hospitalario.
Hemos visto los cambios de antes y después del taller. Cuando recibíamos los bebés, la mamá pues se quedaba en el expulsivo, el bebé se llevaba los cuidados, se quedaban en bacinetes, siempre, ¿verdad?, abrigados, pero ahora es inmediato. El apego realmente sí es un apego precoz.
Uno de los mayores beneficios ha sido potenciar ese apego precoz de ese recién nacido con la madre, facilitar definitivamente esa empatía, ese amor que tiene que existir desde el minuto cero de ese recién nacido hacia la madre. Definitivamente han sido logros muy significativos y que ya los vamos poniendo en práctica.
Ha traído un gran impacto positivo de prácticas sencillas, simples, que no se requiere más que cambio de actitud, que antes no lo realizábamos.
Cuando el niño se le coloca a la madre, se seca bien, ¿verdad? Y se le pone el gorrito. El bebé, al momento de ponérselo aquí, él tiene esa búsqueda.
Y él busca, por instinto, alimentarse. Eso es muy hermoso.
El hecho de tener a su bebé desde el primer minuto de vida, eso les ha ayudado a ellas psicológicamente a sentirse bien, a sentirse seguras, a saber que su bebé está bien.
Estamos teniendo en nuestras manos una vida nueva, un ser humano indefenso que depende de nuestros cuidados y del empeño que nosotros tengamos para poder recibir a ese bebé de la mejor manera.
Okay, welcome back, everybody. We'll give everybody a minute to sit down and find their seats. Welcome to everybody who's online, joining us from around the PAHO region and other parts of the world. Happy UHC Day, Universal Health Coverage Day, to everybody here in France, Lyon, France, rather. It's been a very long day. And to all of those joining us online. I'm Bruce Aylward. For those of us joining online, the Assistant Director General at WHO, responsible for universal health coverage across the life course. And I'm honored to be hosting for the 3rd time today, introducing a universal health coverage event. For those of you out there in PAHO joining us just now, this is our third event today. We started in the dark early today, celebrating UHC Day with our colleagues in Southeast Asia and the Western Pacific, where we had some fantastic interventions talking about the theme of this UHC Day, which of course is health. It's on the government. UHC Day, of course, is an opportunity for all of us to reflect again on the importance of universal health coverage, to recommit to some of the things that we need to do going forward to achieve this goal, and most importantly, often to launch new initiatives, new commitments, as we will be doing today, because I think Ernesto, sitting next to me, you're going to release the new PAHO report on universal health and let us know where we are in the region and where we're headed. Great, we look forward to that. And we're delighted that we also have with us, we're absolutely honored to have His Excellency Minister Jerome Walcott of Barbados. Thank you so much for joining. And Minister Santiago Garcia, Vice Minister, pardon me, of Paraguay. Welcome. And as well, we have, of course, our WHO representative from Argentina, Eva, who will be wrapping up. But with that, I want to say once again, happy UHC Day to everybody, especially our colleagues out there now in the PAHO region. And I'm going to hand over to Calypso, our Director of Health Financing and Economics in Geneva, to moderate our last session of UHC Day.
Thank you. Thanks, Bruce. So it says here good morning, so it's clearly not the morning anymore, but hello and welcome. So before we start, just to repeat the Zoom rules and let the Zoom audience know that we'll have simultaneous interpretation in English and Spanish. And to choose the language, you press the globe-shaped button at the bottom of the Zoom screen. So let me start by introducing Dr. Barbosa, the director of PAHO, who has sent us a video message, which we're about to hear.
Buenas tardes a todas e todos. É um honor para mim acompanhar à distância este evento del Dia de la Salud Universal, em que reafirmamos nosso compromisso com a saúde como direito fundamental. Este ano, o lema Saúde Universal, acesso equitativo com proteção financeira, destaca a urgência de garantizar que cada pessoa em nossa região tenha acesso a serviços de saúde de qualidade sem sofrer dificuldades econômicas. Hoje, estaremos apresentando nosso informe regional mais recente, que titulamos Avanços hacia la Salud Universal en la região de las Américas, abordar as necessidades insatisfeitas de atenção, cobertura e proteção financeira por meio da atenção primária de saúde. Esse informe reflete nosso compromisso de avançar hacia a saúde universal em uma região com grandes logros, mas também com retos persistentes. A pandemia por Covid-19 expôs vulnerabilidades profundas em nossos sistemas de saúde, como a fragmentação, barreiras de acesso e desigualdades que afetam desproporcionadamente a populações em situação de vulnerabilidade. Como mostra esse informe, o caminho para abordar esse desafio é fortalecer a atenção primária de saúde. Ele será clave para assegurar o acesso à atenção e fortalecer a resiliência e a equidade de nossos sistemas de saúde e, principalmente, atender as diversas necessidades das comunidades. Em las Américas, as necessidades insatisfeitas de atenção afetam desproporcionadamente a las populações de bajos ingressos. E essa barreira de acesso tem profundas consequências para a saúde e para o desenvolvimento humano. Em países com maiores níveis de desenvolvimento, essas necessidades suelen ser menores, mientras que em los países de ingressos médios e bajos de nossa região podem superar o 30%, com taxas de mortalidade evitáveis mais altas. Permita-me continuar agora em inglês. I will now switch to English. Universal Health Day reminds us of the importance of eliminating both financial and non-financial barriers so that no one is excluded from health services. In the Americas, many people face high treatment costs and have inadequate insurance, while other factors like transportation issues, long wait times, and negative experiences with providers also limit access, even in countries with high levels of coverage. I want to highlight the fundamental role of the universal healthcare partnership in the Americas. Through this collaboration, we have supported our member states in their efforts to build resilient health systems that prioritize equity, solidarity, and the right to health. I'm deeply grateful to our donor partners in this partnership, whose commitment has been essential to advancing this mission. Their support has enabled us to implement interventions that address local needs and strengthen health systems. I believe you will all find in this report new insights and reflections on the present and future paths to accelerate the transformation of our health systems. The data and the perspectives provided in the report reinforce the evidence for our call to action. We must invest in health systems that serve all people and protect the populations in situations of vulnerability from health expenses that can drive them into poverty. Finally, I extend my gratitude to our member states and partners for their dedication to advancing equitable and resilient health systems based on primary health care. This commitment is fundamental to making the vision of universal health in the Americas a reality. I leave you with one final message. Let us continue to join forces to build equitable, strong, and resilient health systems. Systems and societies where everyone can access quality services without facing financial hardship. Once again, thank you very much.
Fantastic. Thank you. Thank you, Director Barbosa. And now we will move on to the presentation of the report by Dr. Ernesto Bascolo, Unit Chief, Primary Healthcare and Integrated Service Delivery in PAHO. And we're missing, you can move the slides? No? So we're missing that thing that you pressed to move the slides. Found.
Thank you very much. It's a pleasure to present the recently published document, Progress in Universal Health in the Americas. The title is Addressing Unmet Healthcare Needs, Gaps in Coverage and Lack of Financial Protection Through Primary Health Care. This publication utilizes the most recent data to provide a detailed analysis of the current state of universal health in the regions, focusing three key indicators. The first one is unmet healthcare needs, coverage health services, and financial protections. This report identified not just current challenges faced by the region, but key policy implications and recommendations for future action on the path to achieving universal health. We can identify the main messages of this report with 6 very important points. The first one is unmet healthcare needs. 1/3 of people reporting foregoing care due to barriers to accessing care driven by both financial and non-financial barriers. We have stagnation in service coverage. After initial gains, the Universal Health Coverage Service Coverage Index has stagnated with a decline in 2021, driven by setbacks in infection disease coverage. We have financial challenges too. Up to 7.8% of the population face catastrophic health expenses, 40.2% forgone care due to the cost. 4, we have non-financial barriers too. Organizational availability, acceptability, and geographic challenges collectively account for over 40% of unmet healthcare needs. We have an integrated analysis in this report. The three indicators: unmet healthcare needs, service coverage, and financial protection, all of these indicators provide a comprehensive view of the care-seeking pathway from initial need to service utilization and financial protection. And finally, urgent action is needed. We need to strengthen data availability and monitoring for all the three indicators, including for unmet healthcare needs, and adopt comprehensive, tailored approaches grounded in primary health care to address both financial and non-financial barriers. I will address the key challenges regarding the three indicators, including our regional report, access, coverage, and financial protection. And as I mentioned before, one of the main concerns in the current situation in our region is access to health services. As shown in this map, across 17 countries, the percentage of the population reporting unmet healthcare needs shows wide variation from 3 to 73%. On average, in our region, 35% of the population faces unmet healthcare needs, a figure that has remained relatively stable for the last 2 decades. This is important because inequity is among countries. There's a clear inverse relationship between national income levels and unmet healthcare needs. High-income countries report 23% of their population experiencing unmet needs, compared to 35% in upper middle income countries and 49% in lower middle income countries. And this inequity is also present within countries. The lowest income quintile reports on average of 38.5% with unmet needs, significantly higher than the 32 observed in the highest income quintile. However, the degree of this gap varies by country depending on health systems architecture. These data highlight the needs for targeted strategy to reduce these inequities and improve healthcare access across all population groups. When analyzing what is causing this inequality in access, we find that organizational barriers are the most common cause of unmet healthcare needs, affecting on average 21% of the population, followed by financial barriers at 14%. However, the nature of these challenges again varies by country. For instance, organizational barriers are predominant in nations like Canada and Costa Rica, while financial barriers are more present in countries such as Honduras and the United States. But we need to know that the COVID-19 pandemic exacerbated unmet healthcare needs across all income levels in every country. However, the poorest population were disproportionately affected, with the highest rates of foregone care reported in countries like Colombia, El Salvador, Paraguay, and Peru. We have experienced recently a deceleration and stagnation in the progress of the Universal Health Coverage Index. The index used to track the SDG 3.8.1 has shown significant improvement over the past 2 decades, rising from 2000 to 2019, and then falling in 2021. In general, the current situation shows that while 20% of countries achieve 80 points of higher, 71 fell within 79 range, and 3 countries lagged behind at 59 points. Despite increasing in public spending on health in the last 2 decades, many countries today in the region rely on direct out-of-pocket spending to finance health systems. The impact of that varies among countries. For instance, Grenada, Guatemala, Honduras report figures exceeding 50% of the current health expenditure, while, for example, Colombia, Jamaica, and the United States have reduced this figure to below 14%. Additionally, in 2019, catastrophic health expenses impact 1.5% to 7.8% of the population in the regions, affecting 15 to 79 million people, depending on the income threshold used. In 2020, 4.4% of Mexico population faced such expenses, while in 2021, figure varied from, for example, 5.7 in Bolivia, 12 in Peru, 4.6 in the United States. This number highlights the uneven financial border of healthcare across the regions. In summary, the region of the Americas made important progress on the path to universal health. However, there's urgent need for tailored territorial primary healthcare strategies to address challenges in our healthcare system due to the variability of unmet healthcare needs and uneven financial border across the regions. These include addressing unmet healthcare needs, coverage, the coverage gaps, and out-of-pocket spending through comprehensive primary health care strategy to improve universal health outcomes. To close these gaps and increase coverage, we need to improve not just financial protection, but also reducing financial and non-financial barriers, such as long waiting time, limited provider availability, with a comprehensive and strengthened primary health care strategy. Thank you.
Thank you. Thank you, Dr. Ernst. That's fantastic, great presentation. Congratulations to PAHO for the report. I think it's great, especially measuring the unmet need indicator. I think that's critically important and shows all the inequalities within and across countries. Fantastic, well done, though it is quite a grim picture. So now we're moving to have short comments by the ministers on the panel. We'll start, first of all, with Minister Wolcott, Minister of Health of Barbados. So, Minister Wolcott, my question to you is, how has Barbados progressed towards universal health coverage and financial protection for the population of Barbados?
Thank you and good afternoon. I must say at the outset that the government of Barbados is committed to universal health access and coverage, because we see it not only as a health matter, but we see it as a developmental and absolutely necessary as it relates to our economic development, recognizing, of course, what can occur in terms economically when a population is ill and not having access to the best of health care. We also recognize that for sustainability and cost effectiveness, that primary health care is absolutely necessary and is a cornerstone of the implementation of universal health coverage. I've just watched the presentation, and some parts of it I'm a bit bothered by, but not surprised. What I can say is that over the years, Barbados has benefited from a public-funded health system, and this has served us well. I know this evening we're also going to deal with finance, and I will come to that later. But as it relates to the publicly funded health system, which has certainly served us very well, we can boast of having free health care delivery at point of care. We have a national drug service that provides medication, essential drugs, to persons free of cost. All medication on the formulary is available free to those under 16 and over 65, but for those who are affected by diseases like hypertension, diabetes, the NCDs, glaucoma, asthma, all medication is free for them if they want it. Of course, there's a persons have the choice, and if you want to pay for your medical care, you're certainly allowed to. But this system has allowed us to achieve a life expectancies of about 78 years. Normally, we have some good survival rates as it relates to women and children. We have certainly, I see there that we have coverage of over 70% thus far in health coverage. But we also can boast that we provide care. Persons need to be sent overseas for any care that is not available in Barbados. This is covered by the government. Having said this, there are challenges. Like every other country, we have challenges. We have the scourge of the NCDs. We have an aging population. 11% of our population is over age of 65. More recently, and it's been revealed since COVID, we see the issues with mental health disease in our country. We also have the issues of financing. We have issues related to climate change. But we are trying to address these issues as we maintain that we must have universal health coverage. As it relates to the NCDs, we've established an NCD commission. We have recently taken to Cabinet a new strategic plan for the control and reduction in NCDs. We've done a number of things. We are looking at reducing the levels of exposure to certain substances. The government has shown its willingness by introducing measures such as sugar-sweetened beverage taxes, tobacco taxes to control tobacco use, taxes to control alcohol. We're about to embark on the elimination of trans fats by the end of next year. So there are these measures. The Commission also looks to helping people to reduce the risk factors. We've introduced school children a national nutrition policy, recognizing that a third of our teenage population have been shown to obese. So we're looking at these things. In addition, there are a number of, we're utilizing a number of entities to help in this entire process. As it relates to the aging population, we have faced, I don't know if it is unique to Barbados, although I heard a presenter earlier today making reference to the issues that the country is facing as regards the elderly population. In Barbados, we have the situation where elderly people are brought to hospital or brought to clinics with medical issues. Sometimes it could be just dehydration. They need to be rehydrated to be taken home. But then you hear that their relatives can no longer care for them. And in this regard, not only are we accommodating them in the geriatric system, but government has embarked on a program called the Alternative Care of the Elderly program, where we pay for them to be housed in private sector entities, not necessarily hospitals. I mentioned mental health, which has raised its ugly head. I believe it was simmering, but COVID brought it to the head. And we're looking at the whole comprehensive change as it relates to mental health policy and moving from the traditional hospitalization of these people, but getting them into the communities. And I spoke of this yesterday in terms of community care at the clinics, where nurses, etc., are being trained to provide this care in these institutions. There's a matter of the polyclinics, and we have said climate change in having them developing resilience, and there's a project to be launched shortly over the next 3 years to refurbish, modernize, and make our health centers more hurricane resilient, and indeed while greening them. And then there's the matter, of course, of finances. PAHO has provided services, PAHO WHO, where we had a number of consultants came to the island and have developed a plan for us how we can deal with the financing of healthcare in our country, recognizing that what we are doing, healthcare costs keep rising, and there needs to be some measure of control in this. And this is something that will engage our attention going forward. The government has the report, and we're supposed to have discussions with the consultants shortly. I just want to mention one thing, that having said this, I've seen a slide that speaks to high out-of-pocket costs for healthcare in Barbados, and it's almost enigmatic, because in a situation where all care is available free, where essential drugs are free, that you could be seeing such a high percentage of the healthcare expenditure coming from out-of-pocket expenditure. Yet when I dig further, I see that 1 in 3 people who are employed have health insurance, yet the cost from health insurance is less than 6%. So it's a little baffling to me, but I'm not a health economist, neither am a statistician. But I just find it a little concerning. So much, however, I would say is that culturally, there are Barbadians who always feel that they must pay for their health care. I had a grandmother who insisted that even though she could go to the clinic, she wanted to go and see her doctor, and she would pay him. And thank you.
Thank you, Minister Walcott. And now we're moving to Minister Garcia to tell us about the experience of Paraguay progressing towards universal health.
Well, muy buenas tardes a todos. Les quiero presentar la experiencia de salud en Paraguay. Es el Ministerio de Salud Pública y Bienestar Social. Al lado dice lo mismo, pero en el idioma guaraní. Somos un país bilingüe por Constitución Nacional. Dice, Tesain Jateco Ponavé, Motenondeja, Paraguay. Estamos fomentando lo que son las redes integradas e integrales de servicios de salud. Ahí tienen el país, que tiene los colores rojo, blanco y azul, en el centro de Sudamérica. A la derecha es el mapa político del Paraguay, que cuenta con 17 departamentos. Es una república unitaria que está con gobernaciones. Tenemos 6,5 millones de habitantes aproximadamente, distribuidos en 406.000 kilómetros cuadrados. El modelo de atención que tenemos en el país es un sistema de redes integradas e integrales en el servicio de salud, que está basada principalmente en la atención primaria en salud. Buscamos promover las buenas prácticas, la calidad de vida de las personas, y que son sustanciales: acceder a medicamentos, tecnología sanitaria, fortalecimiento y la capacidad instalada en carteras de servicios. El Paraguay está construyendo ahora, tenemos un gobierno nuevo de hace 15 meses, y el nuevo presidente de la República está sumamente comprometido con el sistema de salud. Tanto es el compromiso que en este momento tenemos, después de 34 años, la construcción de 6 hospitales de gran envergadura en todo el territorio nacional, cuya construcción va a empezar en 2025. Ahora, en 10 días más vamos a inaugurar un hospital de 200 camas. Va a ser nuestro primer hospital digital totalmente, con un sistema que lo llamamos SIS, que estamos desarrollando con la República de Taiwán, en donde todo el acceso y la información del paciente está digitalizado, y también en la parte de internado. A partir de ahora todas las unidades y los hospitales que se estén por inaugurar van a estar totalmente digitalizados. En cuanto a la digitalización del sistema de salud, cuando esta administración entró, había 237 establecimientos con el sistema informático. Hoy, a 15 meses, estamos con 700 establecimientos ya con el sistema informático, creciendo prácticamente en un 300%. Los principales avances que tuvimos en el desarrollo de las políticas públicas en salud, el sistema universal, el acceso a la atención médica, la salud mental, que es algo muy importante que le voy a comentar después, la prevención y control de enfermedades, salud sexual y reproductiva y la respuesta a emergencias sanitarias. En el primer ítem, el sistema de salud universal, las nuevas unidades de salud de la familia, es la APS, la atención primaria en salud, a través de las unidades de salud de la familia, que son la puerta de entrada al sistema de salud. Hoy tenemos 937 unidades de salud funcionando en el país. Para cubrir el 100% de la República necesitamos 1.710 unidades. En estos próximos meses vamos a completar 97 unidades nuevas que se van a estar inaugurando, y durante el periodo gubernamental estamos queriendo construir entre 300 y 400 unidades más, de manera a abarcar todo el territorio nacional. Los nuevos hospitales que le estaba comentando, que son 6, la reorganización del sistema integrado de salud, que estaba muy fragmentado y tenía muchos nombres, hoy lo simplificamos, lo dividimos en niveles, y en las unidades de salud familiar, los centros de atención especializada, los hospitales distritales, hospitales generales, hospitales nacionales generales y los especializados, contando de baja a alta complejidad. En este punto, en el acceso a la salud, la atención primaria de salud a través de las unidades de salud de la familia, que tienen una atención de lunes a viernes de 7 a 15 horas, trabajamos mucho en ese punto porque los trabajadores de los barrios no pueden acceder en ese horario al sistema de salud ya que están en sus lugares laborales. Entonces decidimos hacer una extensión del horario de las unidades de salud de la familia, llevándolo de 15 a 20 horas. Y en algunos hospitales también de la capital y el departamento central, que es en donde se concentra el 40% de la población del país. Organizamos maratones quirúrgicas, acortamos las listas de espera de cirugía, hicimos 3.000 cirugías en 15 meses. El Servicio de Protección Social también está trabajando en eso. Y solamente en la franja horaria del horario nocturno atendimos cerca de 600.000 pacientes en 15 meses. Estas son las unidades de salud familiar, hospital distrital, hospitales regionales y los hospitales especializados. APS cubre toda esa parte, la asistencia del seguro social. Nuestro sistema de salud está fragmentado y segmentado, siendo que el Ministerio de Salud Pública, o sea, la asistencia pública atiende más del 70% de la población, el seguro social atiende alrededor del 20% y el resto se divide entre la medicina privada, la sanidad policial y la sanidad militar. En cuanto a la salud mental, dimos un paso gigantesco en lo que se refiere a la salud mental. Teníamos un solo hospital psiquiátrico en el país que tiene más de 130 años y más bien que nada era un lugar en donde las personas iban, suena fuerte, pero iban a depositar a sus familiares, a dejarlo ahí. Teníamos personas que estaban internadas hacía más de 30 años en un hospital psiquiátrico. Hoy día, en 2022 se promulgó la ley de salud mental, en 2023, en diciembre se reglamentó y hoy día estamos dando un salto en lo que es en la salud mental. Por primera vez cerramos en Paraguay el hospital psiquiátrico de larga estancia. Hoy ya no existe. Desinstitucionalizamos cerca de 64 personas que los sacamos en hogares sustitutos, en hogares de adulto mayor, donde reciben una atención digna y están cuidados por enfermeros y compartiendo y teniendo tareas como cualquier persona que esté sentada acá entre nosotros. Nos quedan 70 en los de larga estancia y estamos trabajando para llevarlos a otros hogares sustitutos y esperamos que en 2025 ese hospital definitivamente quede sin pacientes de larga estancia. En esos lugares habilitamos 2 pabellones de corta estancia que son para atenciones de urgencia, en donde cualquier crisis de salud pueda estar ahí, vayan, consulten, se internen unos días, ecualicen su salud y puedan ir de vuelta con su familia. En cuanto a la descentralización de la atención de salud mental, estamos trabajando con los médicos de la unidad de salud de la familia para que puedan ellos tener la capacidad de detectar algún problema de salud mental en todo el territorio nacional y puedan hacer la derivación correspondiente a los centros especializados. En cuanto a prevención y control de enfermedades, también estamos trabajando en un registro único de pacientes oncológicos, ya que estos pacientes son una población importante en nuestro país y están atendidas tanto por la salud pública como por los otros sistemas de salud, y no hay un registro definitivo de cuántos oncológicos tenemos hoy en el país. Eso está en marcha y esperamos que en este 2025 completar esa lista y saber exactamente cuántas personas tenemos con una enfermedad oncológica y nosotros cómo podemos de esa manera ayudarlos a tener su medicación y los estudios en tiempo y en forma. También tenemos el registro de pacientes diabéticos tipo 1 y 2 y gracias a eso estamos comprando y dotándole de toda la medicación necesaria a través del programa de diabetes. El registro de pacientes hipertensos también trabaja de la misma forma y garantizamos la medicación en todos los niveles de atención a todos los pacientes, desde los medicamentos de menor costo hasta los de más alto costo, que son los medicamentos oncológicos. En cuanto a la salud sexual y reproductiva, estamos trabajando para disminuir la muerte materna y fetal, aumentamos los servicios con mamografía que teníamos 24 en todo el país, hoy en día aumentamos a 56 mamógrafos distribuidos en todo el país y lo estamos haciendo informando por telemedicina en un plazo de no más de una semana. Perfecto. Las políticas de respuesta a emergencia sanitaria han incluido la gestión de crisis y la inversión en infraestructura sanitaria, nuevos hospitales que están alejados de la capital de manera a evitar que esas personas puedan hacer un viaje tan largo con sus familiares para hacer un tratamiento. Queremos que estos pacientes se traten en su zona de vivienda. Nuestro patrón hoy es el gold standard. Nuestro gold standard es el teamwork, good work, successful work. Muchas gracias. Aguille.
Wonderful, fantastic, thank you. And now to close, we will turn to Dr. Lopez, the PAHO WHO representative in Argentina.
Thank you very much. Good afternoon, good morning for those of you in the region. It is a real pleasure for me today to close this session of the launch of the report. A report that provides us with a very strong overview of the situation in the region, but it also gives us a deep reflection as to the road ahead. So first, we have seen that significant gaps prevail. So unmet healthcare needs, there's barriers that go beyond financial, so geographical, organizational specifically, and the gaps affect disproportionately low and middle income countries, vulnerable populations, and they're closely correlated with avoidable mortality. And interestingly, despite the advances that we've seen in closing the gaps in health coverage, there's a couple of reflections that might be food for thought. One is the increase of coverage in essential services has not gone hand in hand necessarily with the reduction in unmet health needs. And we've seen a stagnation. So this is food for thought as we move forward, working and trying to achieve universal health. What does that mean? And we've seen that we continue to have lack of financial protection, and there's way too many still in the region with catastrophic health expenses. But what's very interesting is the report also provides us with a way forward, like a roadmap as to where do we want to go. This is something that we've been discussing also over the last couple of days. And one of the key issues, as discussed also by the two ministers that are here today, is primary health care. So this is, we know, the foundation to build an equitable and a resilient health system But to achieve this clearly, and we've seen this by the ministers, we need targeted, comprehensive approaches, interventions, and addressing the challenges that primary healthcare services have in different countries. So this targeted approach in country level is very important. And when we continue thinking about this, we see that we need more integration. We've been discussing about it, integration in terms of programs, communicable, non-communicable diseases across the lifespan. How do we ensure that we increase efficiencies in how we work in primary care, to make sure that we reduce the burden on the system, to make sure that we are more efficient for patients and for families and for teams in those areas, in those sessions, and making sure that we apply the territorial approaches to the primary healthcare setting. There is a final area that I'd like to make us think about as we move forward in this issue. And it has to do with commitment, and it has to do with how we leverage today's context. It's clear that we need to redouble how we work together, how we work between international organizations and governments and civil society. How do we bring along other actors that are not so present in our partnerships today, like the private sector, like the young people? And this is very important because each of these actors hold a key to addressing some of these challenges that we have not been able to tap on yet. So as we work together in identifying how do we set out to the next steps, we need to ensure that we have comprehensive strategies from each of the actors that in the end would be more than the sum of the parts that we would have done independently. Member states, and we've heard about that from our ministers here, need this political leadership. We've seen some countries that really are at the forefront of this. And we need to think, how do we help to identify the incentives that can align the changes in those policies that are beyond health, but that need to be changed to address the universal health coverage agenda. And particularly in the countries where we have the centralized health systems or where we have federal governments, we need to think about how do we leverage these opportunities? How do we work together and embed some of these ideas, some of these new ways of doing things in the different jurisdictions in our overall approaches to addressing the remaining challenges that we still have ahead? Final thought is for us at PAHO and at WHO. What does this mean for us? I mean, we've been pivotal in advancing the agenda, but we have those still challenges prevailing. So as we set out to the next steps, how do we do this differently? How do we work better together? What is needed? And one of the things that maybe we need to think about is how do we come out of our comfort zone to explore ways to expand our technical cooperation, to ensure that we foster innovation. We talk about telemedicine, but what does it mean to scale this up? We talk about artificial intelligence, but what does it actually mean in our day-to-day? How do we use it, really applying it to primary healthcare? But we need to go beyond that, analytics of big data, identifying ways to more efficient resource allocation, thinking about these differences also across territories, across needs, across populations, etc. And how we work across sectors. We keep talking about it. We need to work together. We need to do it better. But we haven't cracked this yet. Private sector, the youth. And as we move forward, how do we actually break the silos? In primary care, we all know, that we have this vertical approach. At country level, we work with it every day. But it's not only at government level, it's at WHO and PAHO as well. So how do we do it? To make sure that we ourselves start by identifying how do we crack this? How do we implement these more horizontal approaches that then we will be able to see through all of these other recommendations in the next reports that we will be doing. So the final word is that We applaud the report, the insights, the roadmap. I think we identify where the challenges are. And beyond all of these, universal health and achieving UHC will not be possible if it wasn't for all of you, from all of us working on these areas. It's such a privilege to be part of this. And I want to finish by just saying a happy Universal Healthcare Day.
Fantastic. Thank you all. Thank you to those who joined via Zoom and to you who stayed on and to the panelists, and have a lovely evening. Bye.
Thank you, UHC 2030.